Here we are.
It's just joined.
Here we are. Right then, let's start off. Hello, everybody. Welcome to January Health in Hackney. Apologies from Jarlath and Councillor David. I'm joined here live by Councillor Snell, Councillor Adams and Cllr Oguzkanli, and we have joining us remotely Cllr Gregory and Councillor Pluvier. Thank you. Hybrid meeting, it's being live streamed, it's being recorded, members of the press might be watching. Please put your microphone on to speak, please only unmute when you're speaking, please keep your cameras on, please don't start conversations in the chat. As a matter of housekeeping, we were due to have an item on, Councillor Davis joined us now remotely as well. As a matter of housekeeping, we were due to have a report from the Kings Park project, but one of the main presenters is ill with COVID, so that matter has been postponed. I'm going to slightly rejig the timetable. I'm going to deal with the Hackney place-based system first, but then I'll deal with the public health spend overview second, and then lastly come to the COVID update. Declarations of interest, I don't believe I've been informed of any other than the usual ones. Councillor David?
Yes, Chair, just to say apologies, my camera would not be on for most of the meeting, but I am here.
Thank you, Councillor David. Noted. Before we start, can I just acknowledge and recognise the news about Tracey moving to Kent to lead, I think it's the East Kent Hospital Trust. I'll be corrected for the exact title. I think you've been 10 years now at the Homerton. You've taken it to outstanding status. I've known you both on the Council of Governors and through these meetings for probably most of those 10 years. We've been incredibly fortunate to have you. I know from the friends that I have work at the Homerton, you're a very well-respected leader there, and you've always been incredibly approachable from a governance perspective, and from what everyone says from a staff perspective. You work incredibly hard. I mean, it's our loss. But thank you for everything you've done in the contribution. Maybe just before we go on, I don't know if there's anything you would like to say, Tracey, but also whether you could maybe just give us some update to the extent you can about your replacement as well. But firstly, perhaps more importantly, anything you would like to say first.
Well, I can only really say thank you, Ben, for that those words. Really, it's been a very big decision. It's closer to where I live, but I have been the Chief Executive at the Homerton for 9 years, but I first came to the Homerton in 1997, and I've been there pretty much throughout, other than for 1.5 years. So yeah, I spent an awful lot of my time in Hackney and the Homerton. So yeah, last year I could barely talk about it without virtually crying. So I'm getting better this year. But so thank you for those words. So the discussion around the reappointment to my post is going to be taken at the ICPB this week, with a discussion around whether this role should also encompass the place-based leader role, which is one I've adopted over the course of the last year or so, following David's departure. So one would hope that we can discuss that and reach an agreement. I personally think that's a very positive move, both for the locality and for the trust. But I mean, obviously that's for others to also discuss as well. And following that discussion, we'll be going out as soon as possible to replace my post, or replace me in my post.
So just to be clear, I suppose irrespective of whether there's still a joined post of, say, the lead of the Chief Exec of the Homerton and the lead of sort of like the local place-based area. My terminology is not yet up to scratch on the new system. But irrespective of that, the board the board at the Homerton still need to replace a new chief exec, and that's in their domain. But before they go and do that, there's going to be a decision at assistant level as to whether it's going to be a join post, presumably, because then you know whether you're advertising for a lead for everything or just a chief exec of the Homerton. So is that right, Rob?
Yes. And Chris is nodding, and we've already had some initial discussions. So Chris and I have spoken. We've also spoken to the mayor. We've spoken to the ICS leadership team as well about it, and I think it needs to be a system discussion and a system decision. But yes, ideally we would go out as quickly as possible once that has been made. So very quickly after Thursday, hopefully.
And how long have we got you for?
Till the end of March.
March. Okay. All right. Well, thank you very much. And also, again, just a 2-minute update, if we can, just before we go into the substantive item. As far as the Homerton's concerned, in terms of COVID from a Homerton perspective, obviously, I think we're starting to see a slight dip in the number of cases, but from a hospital perspective, because of the lag, are you still seeing an increase, or is it starting to dip?
I'll probably describe it as plateauing. And it's oscillating a little bit, but of course the number of patients, or the number of patients that are reported to have COVID that you're seeing on any reports, a number of those patients have been found to have COVID once they've been admitted for something else. So a rough gauge would be 50-50. So the numbers overall are plateaued, and they're around just under 100. And we're probably operating at a 50-50 split between those who have been admitted and then incidentally found COVID and those who have been admitted with COVID. The hospital has been, particularly over the past week, has been incredibly busy. That's as a consequence of North East London generally being very busy, not necessarily solely to do with COVID, but the combination of the COVID patients and then the usual winter patients have made everything very, very tight. We were expecting a pretty dire weekend, and actually it seemed to level out over the weekend. And collectively within North East London, I think we all sort of managed to keep our noses above water. We have been working quite carefully with and working quite hard with the outer boroughs, so not City or Hackney, but the other boroughs, in order to get the out of area patients discharged safely back to their areas as well, which there was a bit of a silting up over the weekend. But yeah, last week I think I would have given on Friday I probably would have given a very dour sort of presentation of the position, but today it feels like it's eased a little bit. We'll see what the next week or two brings, because those are the whole of sort of January is normally quite a difficult period for us anyway, even pre-COVID.
And staffing levels with the virus, I mean, what we've heard sort of a tripling nationally. I think the statistics I heard was a tripling of absenteeism because of COVID.
Yeah, we still continue with a high number of staff off, either sick or COVID positive, and there's a bit of a mixture of everything. But nevertheless, if staff are tested as COVID positive, then obviously they need to follow the isolation rules. So staffing has been stretched. But again, we're seeing now the group of staff who were positive over the sort of Christmas and New Year period coming back into circulation. So again, we're managing just about to get by on that, but it is pretty tight.
Thank you for that update, Tracey. So I've got Councillor Snell has got a question, and then I'll just introduce the substantive item. Councillor.
Thank you, Tracey. If the chair can be a bit cheeky, I thought I might ask for some clarification on this quick COVID update. What I found interesting, because we know from what's been said to this committee before, that actually tests for COVID, lateral flow tests or anything else, aren't 100%. People exhibit long COVID without actually testing positive along the way. And I'm just interested if you could just talk us through the process of what happens when people go in the Homerton, because that's a remarkable number of people who are admitted and only subsequently found to have COVID. So is it a case that every new person who comes to the hospital is treated in a way that ensures COVID does not get spread? And then how is the identification that they have COVID triggered as their treatment progresses?
So I think probably the key thing is we have a quick turnaround test in A&E that's not a lateral flow. So it's a specific test that we do in A&E, which gives us a pretty reasonable view about whether a patient has got COVID or not. That's not a lateral flow. So, for example, there was one of our doctors who was doing a night shift at the weekend who had a lateral flow test, but came in to get this specific test to see whether she could continue to do the shift in the evening because we needed her to. So all patients get tested through that process.
Does that answer your question, Councillor Snell?
I don't think I've quite. So if I understood what you said earlier, you said 50% of people come in as identified COVID sufferers, and 50% of the people now identified with COVID came with something else. But then you've said the initial test is a quick test. But is it quite accurate? Is that the main test that's picking up the fact these people are actually suffering from COVID? Is that what you're saying?
Yeah, so I suppose, yeah, so sorry, I'm probably confused. So there are patients who are coming in to be treated for COVID, and then there are patients who are coming in to be treated for, say, a cardiac problem, but also have COVID, but are not necessarily being treated for their COVID as their primary diagnosis. So
thank you.
So in the numbers, there'll be some COVID patients, some COVID women who are coming in to deliver their babies.
Yeah. Yeah. No, but
So
thank
they're
you, Tracey.
not treated necessarily for COVID, but they're COVID positive. So they then appear in the numbers that you will see.
Thank you, Tracey. I'm going to now move to the first substantive item, number 4, in terms of City and Hackney's role as a place-based system within the new structure. So I suppose just to try and frame the discussion as best I'm able to, I think those of us who would sort of attend meetings on a North East London level have got some understanding of the systems that are afoot there and the discussions there in terms of governance and how the system will work. But at the level below that, at the City and Hackney level, I suppose what I'd sort of like to try and understand, facilitate a discussion on, is what will the structure look like? Because we've moved from a system whereby City and Hackney CCG has had its 400, 500 million pounds per year. It's commissioned Homerton, it's commissioned services. It's had a sort of an independence to do that. To what will the new system, and we've also had a clear sort of understandable accountability line, say with Mark or David Mayer before. We're now moving into a different system where we've got someone as Tracey's role, which may well be Tracey's replacement as well, Chief Exec of the Homerton and the place-based area. But how does the accountability, how does the governance system, what decisions are being made locally? Is there any budget, going to be any budget spend to spend locally? How everyone's role fits in? So I suppose that's the sort of just trying to get some sort of understanding. We also appreciate a lot of these discussions are probably still happening live now, but and some of them may be sensitive. But the best you're able to sort of give us shape some idea of what the debates are would be helpful. So if I can go to. And I think also just to add on is, as I understand it, we were going out to recruit one extra role. I'm not sure if that has yet been appointed to. That was, I think, a shared role between the council and the CCG. I'm not quite sure whether, sort of with Jonathan's title, whether that's part of his role or how this will work going forward. So maybe over to you, Tracey, and then and then maybe we could hear then from Jonathan and Nick as well.
Yeah, so I think Jonathan and Nick hopefully will do most of the talking. So just to say, most of the questions you've just posed there, Councillor Hayhurst, as you suggested, are probably continuing discussion. So some of this is about the balance between the ICS and the ICPB. And I keep getting my terminology wrong as well. With regards to the post that you're referring to, so that is the Director of Delivery Development, and with the Christmas and New Year period, there's been a bit of a delay in just getting the interviews sorted, but that advertisement is closed. We have applicant, and we will be interviewing. So that is the post that will be joint between the local authority and the health side. So that post hopefully will be in place within the next few weeks. Nick and Jonathan have had probably more involvement in the discussions with the ICS with regards to the place-based development. So if I hand over to Nick first, and they'll just run through some of the issues that they've got embroiled in over the past few weeks and months.
Thanks, Tracy. Hi, everyone. My name's Nick Ibb, and I've been supporting the place-based partnership work over the last 2.5 years in various guises as we've been doing different pieces of work around the integration, the health and care integration agenda. I think one of the things to remember in everything we're thinking about the new ICS structures and the kind of legislation is that actually at the place-based level, at the local authority level, the work we're doing very much is an evolution. It's a building on partnership arrangements which have been developing and evolving with a range of partners over a period of several years. I suppose the key difference is the changes that have been happening recently are that City and Hackney CCG, which previously had led the integrated care program structure and had been the kind of key partner in a way with the merging of the seven CCG health partner, but with the merging of the 7 CCGs last year and creating a NEL CCG in readiness for a NEL integrated care system, Oh, sorry, I was reading the note there. We've been putting in place we've been putting in place partnership structures a year ago, which are the ones which we have in place at the moment, which we will evolve to then formally be a place-based partnership within the integrated care system. All of these things are dependent on legislation for integrated care systems. They're created by legislation which is still within Parliament. So hence, you probably may have known that the plan was for the new structures to be in place by the 1st of April this year, and those have been delayed. Those arrangements have been delayed to happen on the 1st of July because the NHS and partners are trying to prepare for eventualities which are still subject to the final legislation going through. So we have at the moment at the place-based level, we have had for some time an integrated care board, which has been the kind of main partnership board in City and Hackney. And when the CCGs merged, that remained the main partnership board in City and Hackney. But as there is now a North East London CCG, City and Hackney's governance link to the CCG was through an area subcommittee, and our integrated care board became a joint meeting of both that area subcommittee for City and Hackney and our formal local series of committees in common between the City of London and the London Borough of Hackney and the integrated care joint arrangements that we'd already had in place. So we have this one partnership governance meeting, which at the moment it links us into North East London CCG, and it also links the two local authorities, and it also continues the history we've had of a way of managing those joint arrangements. And next year, when we go into the integrated care board, integrated care systems, we as a local place-based partnership will be pretty much operating in the same way that we have been doing. It'll be the other parts of North East London which don't have the arrangements that we already have in place, who will be putting similar arrangements in place to the ones that we already have. And so I started by saying that these changes in terms of the creation of the integrated care system and the link between our place-based partnership and that system will really be an evolution of all of the work that happens locally. For a long time, we've had our neighbourhoods programme, we've had the formal joint arrangements, we've had the distributed leadership between the different health and care organisations, the Homerton East London Foundation Trust, the GP Confederation, Adult Social Care, wider social, local authority services, the community and voluntary sector. All of those partners have been working in formal arrangements, and we've been developing closer integrated care at the service level through the neighbourhoods programme over several years. So these new arrangements at the wider North East London system level really enable us some flexibilities and opportunities to further formalise that. But they're very much, for us in City and Hackney, a way of evolving our approach. And there was something about delegation and the money that the CCG had before, and there is, as Tracey alluded to earlier on, there are ongoing discussions about all of these things. And one of the issues is how the financials flow through what happens at system level and what happens at place level. But the programs of joint work between partners remain, and the delivery that we have around neighbourhoods and a number of other areas remains, and the formal arrangements we've been making as partners, working actively together to deliver area differences in children's services and prevention, in all of the areas that we've been working for some time, continue. There are technicalities we can discuss about boards and delegations and powers between the ICS and the place-based partnership, but it's easier probably to answer people's questions about that. I should hand over to Jonathan, who may make that slightly clearer than I have. Perhaps that's been a bit complicated, but I hope.
Just before we go to Jonathan, can you just explain, I mean, on some areas to do with the structures, we've sort of heard that there have been strong recommendations or guidance notes coming down from NHS England about how things should operate, for example, at the ICS level, as to whether the council representatives should be elected representatives or chief execs or officer level. The things like that, there's been strong steer coming down. Has there been sort of a strong steer coming down about the funding arrangements, that everything should be commissioned and flow, or most of the money, at an ICS level, or vis-a-vis at a more local place-based level? Is there sort of strong steer national guidance on that at the moment that's sort of binding people's hands, or is it still very much for each ICS to make its own decision on that?
I think the framework is quite permissive, and there's a real eagerness to ensure that there isn't a one size fits all, which doesn't work in different parts of the country. So I think there is still that maximum flexibility, which is part of the difficulty of partners agreeing those kind of vertical and horizontal questions about how provider organisations work most effectively. Yeah, so it's the latter.
Over to Jonathan.
Thank you, Chair, and it's nice to be back at Health Scrutiny and see lots of familiar faces. Jarlath asked me to say a little bit about the Integrated Care Convenor role, which I'm happy to. It will be fairly brief, and then maybe I can pick up on some of the things that Nick said. So essentially, the Integrated Care Convenor is a part-time role that was initiated by David Mayer when he was leading the CCG. And essentially, it involves supporting the leadership of the system, which obviously is Tracey and others, in developing a place-based partnership. So in the beginning, that was very much around supporting provider partners, including the two local authorities, to develop a formal provider alliance. But as the ICS policy came into view and it became clear that we were going to be asked to work in a different way, it's moved towards the development of a place-based partnership. So it's working alongside Tracey and Nick and others in developing the governance for these new ways of working, particularly in my case, how the Integrated Care Partnership Board is going to work, and also working with colleagues in NEL to understand how they see the places in North East London working in and of themselves and how they work with the ICS. I've also got a particular focus on developing our People in Place group. So that is the group that sits underneath the Integrated Care Partnership Board and oversees PPI, equality and diversity. And I have a lead role in supporting the health and care system's relationship with the voluntary sector, which has always been critical. And we really want the voluntary sector to be seen as and to be able to act as an equal partner in the health and care system going forward. And I think Nick touched upon this. I mean, one of the parts of this role is ensuring that we can build on what has been for many years excellent partnership working across City and Hackney. So trying to work both within City and Hackney and to impress upon NEL colleagues what we've managed to achieve to date and what it's really important that we preserve, because we think there are certain things that have laid the foundations for that effective partnership working. So having a very constructive dialogue with NEL, where we may sometimes argue that there's something that we would like to see in City and Hackney, and it's important for us because of reasons of historic relationships. So I think a really good example of that would be, I think in City and Hackney for a long time, it's been important to health partners that there is democratic accountability in health and social care. And so through what was the Integrated Commissioning Board and has become the Integrated Care Partnership Board, we've always had significant representation of elected members in decision-making groups and forums, and that's just relatively unusual in the rest of the country. So we've had really useful conversations with colleagues in NEL about why that's important to us and why it's really important that we're able to maintain that role for elected members. But I think it's also shaped some of the thinking in other parts of NEL. So I think other parts of NEL will look at greater involvement for elected members. Obviously, there are some specific legal issues around whether elected members can serve on the Integrated Care Board at a North East London level. In terms of place-based arrangements, I think we've led the way and pointed others to the benefits of having elected members really intimately involved in some of these key decision-making forums. So I guess in summary, the Integrated Care Convenor role, in any system, there are operational and then sort of strategic governance relationship type elements, and the convener role helps lead on the key aspects of strategy, governance and relationships. And Tracey's already talked about where we've got to in terms of the director of delivery role, and there'll be further shaping of what the team that is needed to support Tracey's successor to make a real success of the place-based partnership. And I'm sure there will be a role that covers these strategy, governance and relationship areas, because it's a really important part of a successful system.
Thanks, Jonathan. And is it my understanding that, I may have got this wrong, that underneath the City and Hackney Integrated Care Partnership Board, there is a Neighbourhood Health and Care Board? Have I got that right? And is it the sort of situation whereby that would be making operational recommendations? Sort of, look, we've done the research, we've banged heads together, this is what we think is best, and then it goes up to the City and Hackney ICB as the governance check, as it were. Is that the rough structure?
I mean, Chair, the way I've described this before is that the ICPB is the what and the Neighbourhood Health and Care Board is the how. So the ICPB is responsible for setting the vision and strategy for the health and care system across City and Hackney, and the Neighbourhood Health and Care Board develops a sort of operational plan for how to make that happen. So Integrated Care Partnership Board sets the vision and strategy, and then on a regular basis says to the Neighbourhood Health and Care Board, how are you getting on with that? Why is this slipping? Where do you need additional support? So that it performs that that assurance role. There is a degree of overlap in terms of membership, so there's several people who are members of both. So it's going to take a bit of, we're going to have to learn how to work with this effectively. But it feels really important that there is a body that maintains a sort of higher level view, and that there is also a group that includes representation from across the partnership that is the kind of executive function, if you like.
Just before I sort of maybe open up more, so what going forward, it may be yet to be undecided, but that, say for example, that Tracey's successor also, as well as being lead at the Chief Exec of the Hobbiton, is also lead of the place-based partnership in City and Hackney. Is it the structure that we envisage, if I've got it right, the sort of like three sort of people under her, the Nick role, Jonathan role, and the yet to be appointed delivery role? Or is that still up fluid in terms of how that future structure may work?
I think Tracey's probably best placed to talk about the structure.
So the person that I'd also add into that list that you've just regaled off is the lead clinical role as well. So Steph Coughlin, who was appointed as a system person, so intended to cut across all of the organisations and to not necessarily be representative of one particular aspect, but to be a person that cuts across the whole system, which is what the delivery development post will be doing as well. I think there's a bit of further work to be done. So I think there's a real balance between having a dedicated system team that is their prime job, and then also having individuals from organisations across the system that take a very strong lead role. So in the same way that I did, having been employed by the Hobbiton, but take a lead, the place-based leadership role within City and Hackney, arguably we need to think about having individuals that can offer that to the system alongside their organisational role. But in my view, that also brings organisations into the system much more strongly as well. And I think if we can manage to pull that off, I think that would be create a stronger web across the whole system. So people begin, I can say this from personal experience, if you begin to have that sort of some of your role thinking about the whole system, it really does change the way you see not only what you're doing within the system, but also what you're doing within your own organisation as well. And I think that's a very positive aspect. So I would be very pro sort of really trying to generate that out of the organisations that exist within the partnership. So another example would be Niall, who works at the Hobbiton, takes quite a strong leadership role within the IT enabler, and should be and does think about what we should be doing as a system rather than what we should be doing from the Hobbiton's perspective. And I think he's probably quite a good example of that. He also does it at an ICS level as well.
Councillor Gregory.
Yeah, I mean, as I'm quite new to this scrutiny, I'd really appreciate some sort of simple explanation about this area, because I find it very difficult to follow. But I just wanted to ask, there's a lot of talk of systems. What do you mean by systems, and what are you referring to when you talk about systems? Are you talking about project management? Are you talking about, I'm not really clear, thanks.
I don't know who's best to unpick that. Jonathan, go for it.
I guess when we talk about the system, we basically mean health and social care across City and Hackney. So everything from the Hobbiton to GPs to mental health services to social care and services provided by the voluntary sector. And it's not a neat system. It's a complex system, but the whole point of having a place-based partnership is to try and put in place some sort of structure and some sort of set of relationships so that what you deliver on behalf of residents with all those resources is greater than the sum of its parts. And I think, in all honesty, even in a place like City and Hackney, where we've had really good joint work and really strong relationships for years, we probably haven't made it much better than the sum of its parts. We know there is more we can do. And probably, like you're probably right, Michelle, language like system is kind of unhelpful because it's a bit cold, but it's really about, everyone says it would be great if things were more joined up around the person's individual needs and everyone worked well together. But in reality, you need some structure underneath that, and you need to manage those relationships if that's going to be sustainable. And that's really what we're talking about when we talk about a place-based partnership or a place-based system.
Councillor Adams.
Thank you, Chair. I was just wondering if you could explain how the place-based system aims to address the issues that exist at the neighborhood level, such as poor housing, social isolation, poor or fragmented service provision that led to the gap or duplication of effort and limited economic opportunities.
Not sure who would like to pick up that. Do I see any?
Can I, Ben? Could I give a sort of boring sort of governance answer to Councillor Adams' question?
Go for it.
So one of the things we haven't mentioned is the Health and Wellbeing Boards. There's one in City and there's one in Hackney, and that's a really important part of the overall governance. So if ICPB is the what, and Neighbourhood Health and Care Board is the how, that's very much in relation to health and social care services. So the role of the Health and Wellbeing Boards is to take this much broader view of all the things that impact on people's health and wellbeing, and things like job opportunities and quality of housing and accessibility of housing, we all know have a really significant impact on people's health and wellbeing. And so one of the drivers at a national level for having integrated care systems like we have in North East London is that by bringing all these organisations together, we've got a better chance of cracking some of these challenges. I think one of the challenges is that with the best will in the world, what is likely to happen is that when you put health and social care professionals in a board together, they inevitably focus on those health and social care issues, and those wider determinants get squeezed out of the discussion. And so the Health and Wellbeing Board really needs to operate in a different way. So the Health and Wellbeing Board's always been interested in the wider determinants of health. It's always had partners like the Homerton and others attending, but I think it's struggled to really engage that range of partners in order to make their efforts really effective. And the Health and Wellbeing Boards have been seen as places that there's a lot of discussion and they're less of action oriented. And I do work with the Local Government Association with Health and Wellbeing Boards across the country. So this is a challenge everywhere. And one of the things people say is, and you hear this in Bristol and in Southwark and everywhere I've been, they'll say that they'll go to a Health and Wellbeing Board and they'll discuss like a really important issue, and people will talk about what their organisation's contribution to tackling loneliness or tackling unemployment could be, and then nothing really happens and no one seems that bothered that there hasn't been progress. And you reflect on how different it is within their own organisations if they say, this is what we're going to do. For example, in a local authority, this is our manifesto. It's checked rigorously on a regular basis, and when things slip, it's investigated and something is done to try and get it back on track. And so Health and Wellbeing Boards, as well as being sort of guardians of everything that impacts on people's health and wellbeing, not just health and care services, I think it's going to have to keep an eye on, it's really going to have to track progress and hold partners to account much more robustly than it has done in the past. So if there are plenty of things that the NHS could do in partnership with local government around job opportunities, for example. This idea of the NHS being an anchor institution that is always going to be there and is always going to have significant resources and needs to think about how it's contributing to local job opportunities, for example. But we need to, if we're going to embark on a project like that, we need to apply the same rigor we would apply to any other project. And I think that's a huge opportunity in these new arrangements, both at North East London and at a place-based level. So I think it's a really exciting time for Health and Wellbeing Boards. But the risk is what I don't think you should do is you shouldn't say to our Integrated Care Partnership Board, what are you doing about employment, or what are you doing about housing? I think that should sit in the Health and Wellbeing Board space, because that should become the delivery vehicle for really making a difference on these wider determinants.
Thanks, Jonathan. Councillor Kennedy's got his hand up as well.
Thank you. I just wanted to come in and build on that. So within the last couple of years at our Health and Wellbeing Board, we've had our parks strategy, and we've talked about how parks and access to open spaces affects people's health and well-being. We've had someone leading on the efforts to reduce knife crime in the borough come and talk to us, because violent crime, and knife crime in particular, affects people's health and well-being. So what Jonathan said, absolutely right. That's where consideration of issues like that sits, and it's the role of a good health and well-being board to have housing officers and designers in, and to think about how housing and what you do with housing can contribute to, for example, intergenerational housing, how housing and the way it's designed can look to reduce isolation and loneliness and enable neighbourliness to happen. That was the first thing I wanted to say. And the second thing I wanted to say builds on that issue of neighbourliness and goes to the core of the neighbourhoods. You know, the 8 areas that are mapped onto our primary care networks. And at the multidisciplinary meetings there are individual case meetings, which in some cases will have a social care professional, someone from adult social care, can have a housing officer, can have perhaps the clinical lead of the primary care network who's spoken to the GP for an individual, and individual cases of complex cases get discussed right there, right at the level where people live. And when an integrated care system really works and is really integrated, that's where it's integrated. And that's where it can actually talk about all those wider determinants of health around an individual. So if it works right, you talk about the general principle at your Health and Wellbeing Board of the wider determinants, and also in individual case meetings for those really, really difficult, complex cases where people have several interconnected issues going on in their lives. You also talk about it there.
Thank you, Councillor Kennedy. And I'll just bring Mark Rickets in now before I go to Councillor Gregory.
Thanks, Chair. Excuse this rather squeaky voice. It's a non-COVID respiratory tedious bug. Just to say that, again, building on that Health and Wellbeing Board, there's been a review, a refresh of membership and approach, the health in all policies approach to the way that Chris has just been sort of illustrating some of the examples has been really, really good. And actually now we have GP, PCN, clinical directors who are now members of the Health and Wellbeing Board. We just, the whole thing has been broadened to really try and bring those links to how you deliver against the health and social care elements of our aspirations that are identified in the Health and Wellbeing Board. And I guess, you know, symbolically, because I co-chair it as the current CCG clinical chair for City and Hackney for the North East London Unified CCG. Currently, I co-chair it with the mayor, and I also co-chair the Health and Care Partnership Board with Chris Kennedy and Randall Anderson from the city. So it's about building those links in reality. So it's a kind of small point, but it does illustrate the sort of in a way that what we're talking about some of that connectivity around the governance of these things. I just thought it's probably worth mentioning that.
Thanks, Mark. I'll bring in Councillor Gregory now, if I can.
Yes, thank you. I think it would be really useful if we helped residents understand these structures, and I wondered if we could do some communication work on a kind of regular basis, because I do know that a lot of people really don't understand some of these structures, just because and they, you know, they haven't maybe gone out of their way to look into them. But it'd be just really useful, because it's almost like there's another level of operation and governance going on, which I think they need to know how that works. So I just wondered if perhaps you could do some communication which could go in either on the council website or somewhere, so that more people have an understanding of these structures, and it's not, it feels like it's quite limited to people understanding the language, the terminology, but I think it's good to have an overview. Thank you.
Yeah, thank you. I mean, I remember, I think when Lansley's reforms came in, I think Jonathan gave a briefing and it handed like a sausage factory diagram to us all about how those structures work. I mean, yeah, I don't know if this is any simpler or not. Jonathan, you've got your hand up.
Yeah, just to say, I mean, you're right, Councillor Gregory, and there is a comms officer who works with the health and care partners, who has been working on something we're calling the guide, which is a guide to how the system works. The trouble is, every time they do a draft, something fundamental changes, but it might be useful to circulate it to councillors on this committee, just to get your sense of, does it tell you something, and is it easy to understand, but more importantly, from your experience, does this feel it strikes the right tone and would be accessible to residents? Because it's a real challenge. Some of this is very technical, and some of it, there's no reason why people, some people would ever want to know. But it's what's really important is that people know if they have an issue or a problem, where to go, and that is changing a little bit. And so I think it's important that we describe that in a way that reassures people, but also explains how the new system is meant to work. But that work is in hand.
I suppose the only other point would be often, I suppose, NHS managers get bashed in the sort of press, national press, but there's obviously, a lot of great work goes on. It makes an awful lot of these decisions, makes an incredible difference to health outcomes. And I suppose there's a problem, maybe a sort of a general point about actually the value it adds, but I think, as Jonathan says, it's very difficult to communicate. Can I just get, where is the mood music at with how much actual resource will come down to a place-based level? What's the feel at the moment? I mean, as I understand it, the acute trust, the Homerton, it will be a funding stream down from the wider ICS patch, and there are sort of possible questions about that. But in terms of all the other spend that the CCG had, funding the GP Confederation, for example, joint working with the council. I mean, I don't know all those different funding pots off the top of my head, but all those other ones, what's the feel? That most of that will come down at the moment, or is what's the update, or what's the feel? Tracey?
So I think most of the out of hospital stuff will come to place, but I'm going to slightly throw another curve ball in, just because I think it's worthwhile us bearing in mind. So running alongside of developing places, as in localities, as in City and Hackney, there is also the development of what is commonly called provider collaboratives. And provider collaboratives are more obvious when you're thinking about acute care, and the Homerton working with the Royal London and with Queen's with regards to critical care, for example, or cardiac surgery services. But there will inevitably, I think, be provider collaboratives for not only acute services, but also mental health collaborative, community care collaborative, and indeed possibly primary care collaborative, of which Mark will probably be able to describe that more. And I think what we're going to have to work through within North East London and then within places is what is the balance of that matrix. So, I mean, you started off by saying, Ben, a lot of the discussions continue to be underway, and that is absolutely true. And one of those factors that I think is going to need to be worked through over the next few months, and several months undoubtedly, will be what does a collaborative mean, and particularly when you're talking about primary care collaboratives and community services collaboratives, and what is important to be in place. My own personal view, and the view I proffer quite a lot in any North East London meetings, is actually I think place should be more predominant. I think there's an argument for networks around community services and primary care, but actually when you're getting down to working with neighbourhoods and the population of 30 to 50,000 and really thinking about how you manage that better in an out of hospital way, that is about the organisations that are within the locality. So I think that's really, really important to make it work.
But just on the spectre of an acute collaborative, I mean, we've obviously got sort of Jackie Smith coming in as chair of governance of BART and BHRUT. There's obviously the Homerton that's essentially by itself there. I mean, do you see, to the extent you're able to say, I mean, is it a forward trajectory where in 5 years you can see arguments being made, or sooner, that there should be shared governance, should include the Homerton, or is that not on the cards or being discussed?
So there's been no discussions that I've been party to with regards to that, and by the very sort of nature of us wanting to go out and appoint to my post, would support that notion of being continuing in the way that the Homerton is always operated in. Again, I think that there is still quite a lot of understanding to be had between how organisations like the Homerton work within place versus how a horizontal arrangement works with it across acute providers. And as I've said numerous times, not now, but over many years, a lot of the success that is reflected in the Homerton's performance comes as a consequence of working as a system. And I'm absolutely clear about that, and was absolutely clear about it when the Homerton Emergency Department was first rated as outstanding. So, that works not only because the A&E team work well, but because of the way that the system works in managing the whole of the emergency pathway, and that's really important. So, no, in short, there's been no discussion along those lines. And secondly, I think it is really important that the focus on place continues, and we actually show others within North East London what can be done by that.
Well, that's good to hear, and thank you for that, Tracey. I don't see any other hands up, so I think we're in a position where we can maybe draw this item to a close. I mean, obviously it's an evolving picture, and so I think now the date's been moved to July. It's maybe around March, April time in terms of further update before, and then we may have your successor in place as well then, Tracey as well. So can I thank everyone for coming and giving us a much better understanding about where we are at the moment. It's certainly helped. It's certainly helped us all understand where we are. So with that, I'll close that item. Those that have come for this item, please don't feel the need to stay on for the next two substantive items on the agenda. We've had Tracey's update from COVID at the hospital. So thanks everyone that came for this item, and I will move on to the next item. Sandra, I did say to Chris that I had a slight preference to deal with the public health spend now and then deal COVID at the end. Is that okay with you?
That's absolutely fine, thank you.
Yeah, just because I think this one might go on more, whereas I think we can manage the COVID update if time's running short more ably. So so this is an item on a public health spend overview. Thank you for the presentation. Where it comes from, I suppose, is meetings that certainly Councillor Snell and I were in pre-Christmas about sort of what the public health budget is and what it may look like in the future. Sandra, do you wish to give us an overview of the presentation, and then we can maybe open it up for questions?
Yes, thanks, Councillor Hayhurst. I'll just give a brief. So I'm getting a bit of feedback.
Okay. Oh, as in feedback from me or
Through
feedback
the
from yourself?
microphone from me, actually. It's I think it is in your you look like you're muted, but it's but the council chamber is not, and it's echoing in my ear and making it quite difficult.
Oh, hang on.
Excellent, thank you. Right, so I'll just give a brief overview because you've all had it, and then all the detail that's not in there because I'm afraid we just didn't have time to pull anything more substantive together substantial, I should say, together because as we started to do this work, then Omicron broke and we all became considerably busier again. So the detail that's not there, the narrative that's not there, I'll give a little bit now, and then the rest you can get in questions. And of course, this is almost like a teaser, and we can come back with something more detailed, and that also gives a bit of that retrospective look that you did ask for, Councillor Hayhurst, but we didn't really have time for at a future meeting. The first graph, though, on page 2 is really just to put in context the amount of grant that we get for public health, the ring-fenced grant, and this is just in the context of what other London authorities get. We could do something similar with all of the English local authorities, upper tier authorities, but it would have just been a massive graph. But the point of it is really to show you that we actually are fairly well endowed from a public health grant point of view. We didn't, but could for a future edition of this, set this both against the things like the population size and even the average index of multiple deprivation for the local authority. What is important to note, though, is that the amount of grant is not related to population size, and it's also not wholly dependent on either measures of deprivation or of public health or health need, and is really much more a reflection of historical spend from the days when the local public health departments were in the NHS. And so areas where, apart from the City of London, which is a unique case, areas where there is a very small amount of spend relative to their population size, of budget, I should say, sorry, relative to their population size, reflects a relatively small spend in the from the primary care trust in the old days. And then on slide 3, this is just showing you how our budget is currently broken down. And again, some of this is historical. And what it shows you, the really big slices, 0 to 5s, sexual health services, substance misuse, children's 5 to 19, these are, and there's NHS health checks actually looks relatively small there, but these are services that we commission, and in fact most of those are things that we are mandated to commission. So we have to commission an NHS health checks programme, although as you can see that's not an enormous amount, although the percentages relative to our budget don't really give you the full sense of how much spending goes on that unless you work it all out. But so the health checks is a significant amount of spend, but sexual health services is millions, and children's health, both the health visiting and 0 to 5s, etc., is also in the millions. And the public health staff costs are a significant, nearly 10%. Actually, that's relatively, you know, people always talk about how the organisational proportion of organisational spend so much is staff compared to what you spend on other things, but actually, as you can see, it's relatively dwarfed by some of these services that we have to commission. But having said that, we actually have a really good staffing establishment compared to other local teams as well, and we can go into that in more detail at another time. And so that was the public health grant. So that's the core grant that is allocated on an annual basis and is ring fenced for public health spending, and for which I have to account, or we have to account as an authority to the Secretary of State on an annual basis. And so we have to send letters of reassurance essentially to say that we spent the money on allowed public health spending. So one of the things I know that you'll be interested to see is this big sort of salmon coloured slice in the bottom left hand corner, which is labelled other local, other London Borough of Hackney public health activity. And the other meaning, it's not within the control of the local public health team to spend, but it's spent from the core grant. And that includes things like additional environmental health officers, a trading standards officer who specifically works on tobacco control, and without whose appointment we wouldn't be able to do some of that wider tobacco control work, particularly around illegal tobacco sales, but which is in support of the wider public health agenda of getting people to stop using tobacco. And so this is money that's spent on things like mental health, tobacco control, young people services that are not within the statutory health services that we have to commission. So for instance, commissioning some work from Young Hackney to deliver health education in schools. So this is other public health spend, but it's not within, we don't control how the work is delivered or who the person is who might be employed. It's spelled elsewhere in the council, and of course we are a public health organisation. You know, the origin of local authorities is around public health issues, not just drains and clean water, but housing and other issues that are really about decent housing, I should say, that are about making sure that people have the what they need to live a healthy life. So it's not unusual to for other parts of the council who don't have specialist public health qualifications or people with those qualifications managing the work or the budget. It's not unusual for them to be doing what we would expect to be normal public health activities. So then moving on to the Contained Outbreak Management Fund, which is one of the grants that we've been allocated for the COVID response. And you can see at the top of page 4, excuse me, had an allocation for 2020 into 2021, and then an allocation for this financial year as well. And there are conditions associated with it, but it's basically been allocated for COVID, spending on the COVID response, the public health part of the COVID response. We do monthly returns to DHSC, and again, they're checking not just that we're spending it, but that we're spending it in line with the grant conditions. And to date, excuse me, to date we've committed the majority of that money, and we've actually just had confirmation from DHSC that we can carry forward any underspend into the next financial year, because it's pretty clear that this whole COVID response won't be over, and we will require to keep some elements on, like some of the contact tracing, probably the testing infrastructure, etc. And some of those are things that we've used this grant to support, and you can see a breakdown of that on page 5. And how we manage this is some of it is what's the word? It's kind of already a given that we need to buy PPE, have a place to store it, and have a distribution mechanism for the PPE. But then some of the other things, as they come up, we have a process where people will bring a paper with a proposal to the Health Protection Board, and then we will agree that spend as a board, and so that's where the governance is, and the board reports, the Health Protection Board reports monthly to the Local Outbreak Control Board.
So Sandra, just to stop you
Yes.
there, so if I've understood it correctly, we'll be from 2021, we'll be carrying forward around 800,000-900,000, and then that will be on top of the 2.8 for 21-22.
That's right. And then whatever we still have an underspend for this financial year, projected underspend for this financial year from that total sum of what we were allocated for 21-22 plus the 800,000 or so that was carried forward. And so any of that underspend we will be able to carry forward again. Do you want me to carry on or answer?
Yeah, please carry on to the test and trace one.
Okay, so the test and trace grant. So that was the first one we were allocated before the Contained Outbreak Management Fund. No, it's the other way around. We had the Contained Outbreak Management Fund money first, and then we were allocated test and trace. I'm getting this completely confused. We were allocated the test and trace funding first, and it was called test and trace, but at that point we weren't doing contact tracing. And so as you will see, again, the way that we've spent the money has been on a number of elements of the COVID response and not just on the contact tracing. And you can also see it was a smaller amount of money, but it was clear after some time that we were going to require additional money in order to be able to continue with the response, and which you can see on the final page, on page 7, that we've used a significant proportion of that for contact tracing and setting up and working with the testing infrastructure. So obviously some of that is being paid for directly and provided directly by the Department for Health and Social Care, but there's some of the local testing infrastructure we manage, and we have a team that does that. And so there's a combination in both the test and trace spend and the Contained Outbreak Management Fund spend that is about the infrastructure. There's a proportion of it that is about the people that we've had to recruit to carry out these various different tasks or programs of work. And then of course there's the bit that will be about some of the consumables and other things that are just required to provide the service. So that's the overview, and I'll stop there.
Thanks. Sandra, so I mean, going back to the sort of the discussions that we've been having prior to Christmas with respect to where there may be, sorry, let me start off with the framing of the debate that, of course, I think we all understand in this room that cuts to local authority spend are not as a consequence of anything to do with sort of local authority, but as a consequence of allocations from national government, and that this local authority has had millions and millions taken out of it over the last 5 to 10 years, and that very, very difficult decisions have to be made, and we all understand that. And so, and that we are now in, you know, any sense of salami slicing has ended, and now there have to be very, very difficult decisions taken, of which we don't want to take. And so there's no sort of blame or anything like that that's going around. It's just trying to understand the position. But there was understanding that there may be going into either the next financial year some reduction in the public health spend. So where is that coming from? Which area? If we are going to see a reduction in public health spend in the next 1 or 2 financial years, which part of the pie is it coming from?
So we're looking at that, and there are opportunities actually for reducing the current spend that aren't necessarily going to have any specific impact in terms of what we do to improve people's health locally. So, and to give an example, although I'm being a bit cagey because we haven't made a firm decision, and I don't want Jane to be watching this and suddenly think, oh my God, she's cutting all my budgets without discussing it with me, because that's not the case at all. But for instance, physical activity for adults, and it's really a bit of a shame that we haven't really had the opportunity to talk about Kings Park today, but we will do at some point in the future. But physical activity, as portrayed in the budget, in the pie chart for adults at the moment, it's about 0.3% of our budget. Completely separately, we're spending money on obesity services, and we don't necessarily. We do have a strategic strategic group that looks at what we do around obesity. We don't necessarily have the same thing in terms of physical activity at the moment, and we don't have a strategic approach to physical activity. What we do currently is spend money to provide or subsidize physical activity opportunities like classes for people, for individual people. It's a relatively small fraction of our population for whom we provide that. And in terms of the population level health impact, we can't even measure it. So we could say, okay, let's stop commissioning those services, save all of that money and do something entirely differently, which either would cost nothing or cost less, because it's not about subsidizing classes. So we actually started doing some of that work around looking at our strategic approach to everything. But of course, and it's not an excuse, it's just the reality that having the capacity and the time to do all of that work has been really difficult over the last couple of years. So I can't give you a firm answer that says this or that. We do have a few current, what we're calling savings plans, but then mostly to do with areas where we were planning to recommission something already, where we can get some better value by revising the contract. So it's actually not particularly helpful to think about public health in terms of how you achieve improvements in people's health and reduce inequalities as something where you pay for this amount of service, and then if you don't pay for that amount of service, you don't get the improvement. Does that
I think we understand. I suppose all it is from a governance point of view is just understanding, and we understand recommissioning and different ways of working are sometimes necessary. I think it's just understanding from an accountability point of view as to where it's coming from, and just essentially holding scrutinizing you and holding you to account about, well, why did you make that decision over that decision, and what have you. But if I see other councillors want to come in, and I'll bring them in a minute. But my understanding is this: that we're possibly looking to a reduction in the budget for the public health budget for the year 22-23, but yet but the areas of the reduction have yet to be decided upon. Is that a fair summary of where we're at?
Not exactly. So we have already agreed some reductions on very specific areas. And sorry, I'm really a bit foggy about this. I just came back from leave today, I haven't been thinking about it, to be honest. So telling you exactly what those areas are, I should have had that at my fingertips, and I apologise that I don't have. But we've done that by looking at where we are recommissioning services, what we were currently spending on them was out of kilter with what other places were spending, where we weren't necessarily getting the best value, where we had the opportunity to renegotiate a contract as we were coming up to, or re-specify, I should say, as we're coming up to recommission. And then because that then gives us some headroom, there's an opportunity for us to redistribute that to those other areas of public health spend. So what I'm not being, so this is being driven by a number of things, and only one of which is the financial pressure in the council. It's also being driven by my desire to make sure that we have the right approach to improving health and reducing health inequalities, which isn't all about commissioning services, and that of the things that we do commission, that we're not just getting the best value for money, but the best outcomes, and that doesn't always mean spending more money.
Sure, I think we understand that. I think it does, and we all appreciate you've done a fantastic job, and you've been under intense pressure, and for understandably, perhaps doing an explanation schedule for us is not, rightly so, hasn't been your priority of late, and we understand that. I think in early course, though, I mean, I think it would, and I'll open up for questions saying, I think it would just be helpful just to understand from a scrutiny accountability point of view, what's been recommissioned. That's say 200,000. We moved it there. Overall, budget's gone down by £500,000. It's come from here. It's come from there. We've given more there, just to give us some idea as to what's happened, just so we can understand and
absolutely.
Have a look at that.
Would absolutely be happy to do that. We just really didn't have the time to get something that detailed together for this meeting, but we can do it for a subsequent meeting.
Thank you, Sandra. Right, so in the order I saw them. Councillor Gregory first.
Thank you very much for this. What struck me when I looked at the pie chart, I was actually, to be honest, I was quite shocked at how much we spend on sexual health services. And then when I was looking down, I saw by comparison how little we spend on obesity and physical activity, because we're all very much well aware that a lot of people in Hackney are obese and have one of the things impacts about COVID is if you're obese, you're at more risk of serious illness, etc. So I wanted to ask you, in terms of the sexual health services, how does that compare to other local authorities? How much of that element of our spending is reactive work, and how much of it is preventative, and how do we monitor the success of preventive work in terms, I mean, does that 22.5% reduce because of preventative investment? Because, or is it a constant 22.5%? As I say, I was quite surprised at how high that was. You talked a little bit about the classes for obese adults and children and physical activities. I wonder, I've actually, my immediate reaction was we should be spending more, but looking at different approaches. For example, summer dance classes in the park, summer activities, outdoor activities, because I think, or just something different, because I think if that's addressed, then people's overall health will improve, whether it's children and adults. So that's my kind of feeling about it. I'm not sure other people agree, but I suppose I'd like to know. Yes, thanks.
Thanks.
Just deal with that now, Sandra, and then I'll bring others in.
Thanks. I'll speak. Shall I speak about the obesity physical activity bit first? Because then, when I address the sexual health stuff, I can bring Chris in, who's actually the expert on all of. No, Chris Lovett, that is. Yeah, so I completely understand the kind of sense that we should be doing more around physical activity and obesity, and I don't disagree that we should be doing more. What I don't necessarily agree is that that means that we spend more money on activities for which a fraction of people, we would only be able to do that for a fraction of people. We would never have enough money, or we'd have to stop doing everything else and spend all of the money on putting on activities if we wanted the entire population of Hackney to participate. And we also know that they won't necessarily participate just because we make the activities available. So we quite often will be providing subsidised activity for people who would do physical activity anyway. And actually what we need to be doing is focusing much more on changing the environment and then supporting people through behaviour change rather than just paying for activities. And that was what I meant about we should possibly stop commissioning those activities and do something in an entirely different way. And because that's much more about not necessarily what we spend, but again, it could be that we decide as a public health team that we want to, and with the support of Councillor Kennedy, to contribute to some work around regreening parts of the borough that actually make it easier for people to be physically active in their environment. That would be money that would come out of the core public health budget, but wouldn't be on something that's directly labelled physical activity, because it would go into, say, parks. but would have the benefit of creating an environment that would actually help people to be more physically active. And then we would of course have to marry that with an approach that is about supporting people with the other elements that are about not just the motivation to do it, but whatever else they need in their lives that are going to help them to get physical activity and healthy weight higher up their personal agenda. And that's why it's never as straightforward as just making things available. Otherwise, we wouldn't, we've got one of the greenest boroughs. We've got lots of great cycling and physical activity opportunities already, and not everyone's taking them up. And there is a significant portion of people in Hackney who are obese, not because the opportunities aren't there, but because the work that needs to be done to support them in other areas of their life, as well as helping them to get more motivated, isn't being done in quite the right way. Just making the activities available or paying more for activities isn't going to cut it. In terms of sexual health, one of the reasons that the spend is so high is that apart from it, that that health services are actually just expensive, is that it's an open access service, and so you can't control access to it in a sense, and in fact you don't want to, because you want people to be able to, if they have a problem, if it could be a sexually transmitted infection, we want them to get diagnosed as quickly as possible and get the treatment they need. But we have been doing a lot of work over the past few years, including developing through our work with the London Sexual Health team, an online service that makes it actually easier for a lot of people to get diagnosed and do tests at home. And that's actually been really useful over the past couple of years during the various periods of restricted movement. But it does mean that if they come up with a positive test, they will still need to go to a clinic and see somebody and get a proper diagnosis and get treated. So some of the spend is around preventive sexual health, including a significant chunk of that is for pre-exposure prophylaxis for people who are at risk of HIV. If I remember rightly, it's about £1 million this year. Chris might correct me on the figure. We also spend money on condom distribution, for instance, but we do need to do a lot more around the preventive sexual health, as we actually need to do much more around, for instance, more preventive substance misuse work. So all of that substance misuse spend at the moment is about service provision as opposed to the preventive work, and we do need to get that balance right, but we are required by the conditions of the grant to spend the money on services as well. Chris, did you want to add anything on sexual health?
I mean, just the only things to add is we have got very high rates of sexually transmitted infections in Hackney. We've had that for many years, and partly that's because of a very young population, quite a large number of gay and bisexual men who live in the borough who tend to have higher rates of sexually transmitted infections. And then also we have been successfully increasing people's access to long-acting reversible contraception, so giving more women choice over their reproductive choices. So and I think as Sandra has been highlighting, what we've been looking to do over the last couple of years really is try to direct people into more cost-effective ways of getting sexually transmitted infections diagnosed by the online service, so that we can then actually invest more money in things like condoms, making sure that the condom scheme for young people is more responsive to the needs of Hackney. So we've recommissioned that in the last few months. And in terms of the PrEP, so the pre-exposure prophylaxis, we've taken some of the money that would normally be spent on providing the clinical treatments for HIV and putting that towards actually a contract which is out for commissioning at the moment, so that we increase access to PrEP from some of our Black communities. So I think in some ways it's a good example of where it does take a little bit of time to kind of turn things around. So you're not just treating ill health, you're actually promoting well-being, and obviously the pandemic has provided in some ways a little bit of an opportunity because more of the activity went online earlier, so it did create that online service, but obviously making sure that people who can't use online STI treatments testing services can actually continue to access services face to face.
Thank you. And I think Councillor Kennedy, you raised your hand. I think maybe in response to the exercise and the greening. So, if it's on that subject, do you want to come in and then I'll move on? You're on mute, Chris.
Sorry, it was just to say if you'd been able to hear from Lola and members of the Kings Park Moving Together team tonight, you would absolutely be in tune with what Dr. Husbands was talking about in terms of looking at how different and simple interventions can get people moving who might not even realize that a little bit more physical activity would be good for them. And that's absolutely what that project is about, and looking at new ways of looking at things rather than just going, oh, well, here's a class in a hall, you should go to it, because we know that doesn't work. And it's looking at working out what does work and what interventions you can do to get people more physically active.
We've got, I think we'll have Lola coming to our next meeting. She couldn't come today. Councillor Oguzkanli.
Thank you, Chair. My question is about public health, mental health within the public health services. In my view, it's one of those areas that is likely to cause significant constraint in the next couple of years. Firstly, do you agree with that? Secondly, how do you see the future of mental health services evolving and funding changing? And thirdly, are we embracing ourselves for influx of needs in terms of mental health, and whether what kind of budgetary constraints we're likely to face, and whether the funding allocated at the moment is going to be sufficient to cover the needs of those patients or recipients? Thank you.
Yeah, thank you. That is a really good question, and I agree that we are likely, in fact, we've started to see already a significant increase in mental distress at a population level, and some of that has tipped over into people actually requiring mental health services, and some of it people self-harming or attempting to. And we have a number of streams of work, including a suicide prevention action plan, for instance. What we spend the money on in the the pie chart where it says mental health at the moment is what we call the mental health network. It's a network of providers, most of which are community-based organisations that provide a combination of sort of preventive and wellbeing support to people to help build their resilience and get them on the path to improving and protecting their mental well-being. And some of it, probably the bulk of it, is providing mental health treatment services, like talking therapies type services, for people with sort of low-level mental health problems. And that is one of the services areas that is up for recommissioning. So we started doing the work on that already. So to my mind, that is not a public health, the treatment services element is not so much a public health intervention, it's a treatment service. And it's forming an important part of the overall mental health service contribution for people in Hackney. But I think the balance needs to be more towards the prevention and resilience. And we're looking at how we strike a balance in terms of making sure that different communities still get that individualized and culturally appropriate opportunity for talking therapies, for instance, but also that we at a population level, we're doing a lot more about supporting people's well-being and building their, I don't like to use the word resilience, it's just kind of a shorthand for saying how do people learn to cope because we all will face things that will cause us various degrees of distress. And for some people, it'll tip them over, and other people it won't. And that learning to cope, knowing that bad feelings are normal and being able to cope, and also to know when to get help, but also to make sure that help is available, is what the network is about, and working closely with our NHS colleagues to make sure that it's much more integrated. So there's about 1.4 million in that budget at the moment.
Sandra, I'm sure you're aware, I think this takes me back about 8 years, where I think there was, if I'm right in terms of whether it was the same budget line in terms of services with Derman and others, that was then at that point withdrawn, and then there was a feeling that a lot of GPs were saying, hang on a minute, we're now getting an increased caseload to us and we need support for the talking therapies, and then it was refunded again. And so just to be, I'm sure you are just,
yeah, so that does sound familiar, and yeah, I wasn't there at the time, and it does sound familiar. And with all respect to my GP colleagues, I don't actually think that it should fall to the public health team to fill a gap in services. If it was some other thing, if it wasn't mental health, we probably wouldn't even countenance it. So there is a negotiation to go on, so that and this is not about creating demand that can't be met by the health service because we've withdrawn the service. But we won't stem that demand if we don't do something more on the preventive end. So we need to strike a balance between the talking therapies bit and the wellbeing and resilience bit.
Councillor Pluto, I've seen you. Councillor Pluto, I'll come to you in a second. Councillor Snell had his hand up first in the chamber, then I'll come to Councillor Pluto. Councillor Snell.
Thank you. Sandra, I think we're on the same page, but I'm not sure this report necessarily makes it completely clear. So if we look at the first table, which has the allocation to all of the different London boroughs and seems to give Hackney about 35 million, is the breakdown that we then see in City and Hackney, the pie chart, does that equate to that figure, the 35 million? Now, so that's the baseline question, because then I'll make the points that I was wanting to make.
The baseline question, the answer to the baseline question is yes.
Great. Okay. So what was concerning, I think, to us when we had our chairs of scrutiny meeting about the potential budget was a feeling that was given that you might be so overwhelmed with what you've had to do around COVID that was making it difficult to come up with new and better interventions. And it sounds as if that's wrong, because Cam asked earlier, Councillor Adams asked earlier, what about the environmental determinants of ill health? And Jonathan said, well, they should be addressed through the Health and Wellbeing Board. And what I would understand, and put me right if I'm wrong, is that when you have the other LBH public health activity, i.e. local services and other departments, in effect you're doing what Councillor Adams was asking about, is looking at those wider determinants under the council's control and ways to improve them. The only final question, so you've reassured me, we're not losing the money, we're just spending the money in better places. The thing that would concern me is obviously that should be guided by our Health and Wellbeing Board and our Strategic Needs Assessment. But I don't like the idea you might just be giving that money away and not monitoring it. If it's public health money, I would hope it's for specific projects, and we do have the resource to manage it and measure the outcomes achieved from the spend of that money. And I'm hoping we're on the same page here, but that's what I hadn't fully understood before.
Yeah, so we are on the same page, and you're right about everything. And we do get to monitor the outcomes and get reports back about the money that we distribute to other council departments. So I know that in some councils, because of their particular financial positions or their attitudes to public health or whatever, or both, the public health ring-fenced grant has not been quite as well respected as it has been in Hackney, and that they've used it for all sorts of things that they there's a much more tenuous connection between the spend and a public health outcome, but that's not been the case here traditionally, and it's certainly not going to be the case under my watch. So when I came in, I questioned everything, like, why are we paying trade and standards to have a trade and standards officer? They should have, other councils do it without having to be paid to do it. But the fact was that training standards didn't have the capacity to do it and wouldn't have been able to do that work if we hadn't supported them with the money to employ another trade and standards officer. But we do know what that person does. We do get reports back about it. They're an integral part of the Tobacco Control Alliance. And so it's not as though we just distribute the money and we lose sight of it.
Thanks, Sandra. Councillor Kennedy's got his hand up, I think, on this area, and then I'll come to Councillor Pluvier. You're on mute again, Chris.
Sorry, I keep taking my hand down, but not unmuting myself. It was quickly to say to Councillor Snell, yes, at the Tobacco Control Board, for example, we look at the seizures of illegal cheap tobacco that have been taken off our street, and we know for a fact that the less cheap illegal tobacco you have on your street, the less new uptake of smoking that happens in your borough. So you can actually see your spend doing good and saving your population.
Thank you. Councillor Pluvier.
I think my question was already answered. Thank you.
Thanks, Emma. Thanks, Sandra, for that. So, I mean, going back to one of Councillor Snell's points, I mean, I presume, obviously, that to what extent is the spend dictated to by the health assessment and the priorities set by the Health and Wellbeing Board? I guess you've got a number of statutory criteria and spending pots you've got to fulfil, but then we're moving to a position, if we're not there already, where on discretionary spend, to the extent that you have it, you're trying to align that with those priorities as per Health and Wellbeing Board and joint strategic needs assessment. Is that right?
Yeah, that's right. So we haven't obviously had an update to the either the Health and Wellbeing Strategy or the Joint Strategic Needs Assessment for a while, although both of those pieces of work are underway at the moment. But from the slightly historical understanding of the needs in the borough, we are prioritising our approaches to public health. Just to respond to something you said about the pots of money, it's not as though we are required to spend a particular amount on, say, health visiting or substance misuse. Again, it's a bit historical, and it's that, but also it's about, for something like, say, health visiting, that depends on the number of children that you have born, the number of families that need support, and the capacity of the team to deliver that service effectively and safely. So we'll have inherited a team of a certain size when we assumed responsibility for commissioning it, but then we can look at that and say, how do they more effectively and more efficiently deliver a service while making sure that not just that we are fulfilling our statutory requirement to commission it and the requirement to the safeguarding elements of what they do, for instance, but also making sure that can you hear me? My thing's saying I've lost. Oh, I have gone. Can you hear me still? I seem to have lost my connection.
We can hear you.
Oh, okay. I just can't see any of you anymore. Okay. So it's not about making sure that they can just do the minimum, but also it doesn't mean that we have to spend that much either. So that's something. So for instance, that's another area where we are recommissioning. We're on the journey to looking at how we integrate our children's health spend with other.
Oh, now we've got a frozen screen. I'll just give it a second to see if we come back from Sandra. No. Okay. I will, because we were nearly at time anyway, so it may well be I'll just draw that. I mean, the one thing, it may be that either of the Chris's could pick up is just that I was going to ask Sandra is that in terms of the discussions such as the public mental health spend in response to Councillor Oguzkanli's question, where there may be discussions as to who should pick that up, is that in terms of public health or is it more GP? I mean, presumably that is something that then goes through an integrated system to be discussed. That's the whole purpose of this. And it goes through that process to come to a joint decision vis-a-vis a situation where we may have been in historically where it happened, and then the GPs are all saying, well, what's gone on? But everyone would be cited on that decision. Is that the mechanism by which that discussion would take place? Chris?
Yes. So you're at a wider NEL level, it would be your mental health collaborative, but specifically at this level, you're the clinical lead for the whole of the place-based partnership, Steph Coghlan, would be talking to the GPs, HUHFT, our public health body, and looking at the whole of mental health provision across Hackney.
Sandra, we lost you. Thanks for rejoining. We lost you, I think, because we are at time on this. We've got 20 minutes left to do the COVID update. Thank you very much for that. To wrap it up, yes, I mean, if we could just see at a point where you've got a little bit more capacity, it doesn't have to be much more than a single sheet, just to understand what was recommissioned, what was saved, and where it was, just so we sort of just have some oversight. Because I don't necessarily think we had that level of detail at the meeting Councillor Snell and I were at, and I think it just helps to give that confidence and accountability. Draw that to a close. The COVID update, is Chris leading on that? So Chris, over to you, 20 minutes. Thank you.
Thank you, Councillor Hayhurst. So I'll just introduce myself, as I think there's new members on the committee. So I'm Chris Lovett, Deputy Director, Public Health for City and Hackney.
Chris, can you turn up your mic or something? You're slightly muffled, or something over it, or I don't know if there's any way to...
Is that any better? So I'm Chris Lovett, Deputy Director of Public Health for City and Hackney. And just before we start, just to record thanks to our health intelligence team who prepared this presentation again for you. So it's been a very interesting month, to say the least. The last update we gave you was on the 9th of December. And essentially we have had the impact of Omicron. Just reflecting back a little bit, it was first reported cases from South Africa to WHO on the 24th of November, and then declared a variant of concern on the 26th of November. I'll share the screen just so you can see some of the data that I'm going to be talking to. I think that should, yes. And so what we essentially can see on the number of the graphs here is that incredibly large increase due to Omicron, which is not just in Hackney, but across the whole of England. Started very much in London and very, very quickly went across the whole of the United Kingdom. What we can also see on this data, I think, is almost a very compelling argument that perhaps we've hit the peak of the new wave, and we're being very cautious interpreting that, because during the week before Christmas, there was significant pressures on the number of tests that were available, and we're continuing to see the positivity rate in Hackney increase. So we think that probably there may well be a further number of cases that are going to increase, or certainly a plateauing over the next couple of weeks due to the Christmas and children going back. And the Office of National Statistics does do an infection survey, which is a slightly more reliable way of giving an indication of what's happening across London and the UK, and that has continued to increase. And so for the last survey period there's an estimated 1 in 10 people have got COVID in London, compared to 1 in 15 the previous week. So we probably have a week or two before we can be really clear that the downward trend that we started to see is not just an artifact due to the Christmas period and New Year period, and also the pressures on testing. You can see here where the Omicron wave started. It was very much in the younger population group. So they went up very, very quickly, especially the 20 to 29-year-olds. You can see that very large increase on the 16th of December. So these are age standardized rates for the different age groups and the period across the top. And we have seen now that that's starting to go down, but we do need to be slightly cautious, as I've said, about over-interpreting the data until we've got a couple of data points from the first and the second week in January. And then the issue that is going to cause a lot of interest is the rates in the over 60s, where you can see that they have continued to go up. The numbers are still fairly small, especially in the over 80s, but obviously this is where if people do get infected with COVID, the complications can be much more serious. And so that is something that's being kept an eye on very, very firmly across City and Hackney, but also in London as well. And then this shows the huge amount of effort that went into providing more testing. As I'm sure you're aware that there's now the change that lateral flow tests are not going to be followed by confirmatory PCR tests. So again, interpreting this data beyond this week is going to be slightly more challenging. But what you are seeing here is the very large increase in positivity, which obviously shows that there are lots of people who are coming forward to be tested who are then actually subsequently found to have COVID. So the positivity rates something that we want to keep an eye on, but it is going to be difficult to continue to interpret this data because of the changes that a positive lateral flow test won't need a confirmatory PCR test. And then this shows the massive amounts of effort that went into the booster program locally. You can see here, so the slightly lighter color blue is the first doses, the darker blue is the second doses, and then these are the booster doses. So on the 19th of December, by far and away that week preceding, we had the most amount of vaccine delivered to local residents in Hackney. We still do have quite a large number of people that still need to come forward to be vaccinated for the first, the second, and uptake on the booster. There is a lot of capacity in the system now. Some of that capacity is being stepped down because of the demand for boosters has been reduced, but we have got still very good capacity. So if people want to get their first, their second, or the booster, then there is walk-up appointments. Nearly all of our vaccination centres almost every day of the week. And then if you're looking at the uptake of the vaccination, you can see that there continues to be quite a lot of work to be done in relation to getting the City and Hackney vaccination levels up to the North East London average, or up to the London average, or to the UK average. And this is very much something that continues to be worked on to give people confidence to come forward and get the vaccination, and making sure that the knowledge that we have that to encourage people to get vaccinated, you often need to have low threshold, so easy to access, don't need to go onto an online portal. And that's something that we've now, with the good capacity in the system, it's much easier to be able to meet. So people can walk in for a vaccination appointment at practically all of the vaccination centres that we have across City and Hackney, as well as across London. And then I think you've heard from Tracey before this item about the impact that COVID is having, both in terms of staff absences, but also in terms of pressures on the hospital. So I'll pause there and happy to answer questions.
Thanks, Chris. I've got, I see some hands. Just quickly, I mean, I saw on a behavioural expert professor was being interviewed on Channel 4 News, I think yesterday or the day before, in terms of sort of the mandatory jab debate, and he was sort of saying, I think, well, he was arguing not necessarily the way to go to win or persuade people, but more community-based approaches, possibly even door-to-door for those that haven't. I mean, to what extent with that funding that Sandra took us through before, are we at that level where we're thinking about maybe mapping communities that are under-vaccinated and possibly doing a door-to-door effort from medical professions who can actually go and speak and persuade and speak to people? Is any thought being given to that?
So there has been very extensive mapping, so we can look down to quite low level areas around the uptake of the vaccine. Where door-to-door vaccinations have been offered in other areas, they haven't always proven to be very successful. People don't always appreciate that knocking on the door and offering the vaccination. I think what has been successful is that consistent offer of where you can get vaccinated, making it as easy as possible for people to be vaccinated. Those people who are vulnerable and housebound have been offered, and there's been very good uptake, I believe, on that housebound vaccination offer, and the same in care homes. But at the moment, it's not something that's being looked at. I think also it would be fair to say that NHS England, Department of Health, and also locally, there has been almost no cash limits on what is possible to put into the system in order to meet the vaccination requirements. So it has been the absolute #1 priority of the NHS during December. Local authority has continued to support as much as we can with communications, with outreach team, and obviously the community itself with the vaccine volunteers. So it's not, I think, around availability, it's more around, I think, making it as easy as possible, and then consistency of message around that it's a safe, effective vaccine that will protect you from serious infection.
Thanks, Chris. I saw Councillor Gregory first.
So, sorry, can I just add?
Sorry, Sandra.
Just in terms of that point about door-to-door versus what the approach we're taking is not so much knocking on individual doors, but it is going to those local areas where we know there's been low uptake, and work and addressing communities' needs and concerns directly, partly through our community testing outreach. We take the tests out, we explain, but also give people the opportunity to talk about the vaccine, and as Chris was saying, point them to where they can go to get vaccinated locally, as well as doing pop-ups in some areas.
Thanks, Sandra. Councillor Gregory.
Yes, thank you. Not sure if this comes within the remit of this of public health, but this week we found out that schools in Hackney haven't implemented HEPA air filters. Some classrooms have got natural ventilation, others haven't. And as infection in schools is at that age range has been fairly prevalent for quite a while now, is there anything you can do to help the schools improve their environments? And that includes HEPA filters, assessing the air circulation, CO2 monitors, and generally advising them, because we are quite far into the pandemic, and so children are kind of becoming like COVID carriers, really. Thanks.
Sandra, just before you answer that, can I bring Councillor Snell in as well for his question?
Mine may be a comment, but I'd welcome feedback. I'd like to place on record my thanks to Helen Woodland, who heads up adult social care. I've long been very concerned that we were doing enough to contact and vaccinate care workers, and in particular the potential loss of care staff. I had a very, very good briefing just before Christmas, and the amount of work that our staff have put in to working individually with people working for the agencies that provide care in Hackney has been extraordinary. And a key part of that, as I understood it, one of the big groups that was resistant were women who were pregnant. And so they were talking to them individually. They were giving clinical expertise, people who could advise them it was safe and talk them through their resistance. And the number of people, therefore, now not jabbed and likely to lose their jobs is absolutely tiny, which is fantastic. Now, my question really, and I think what we're hearing is from Chris, is it's happening anyway. If there is a cohort of the population, like pregnant women, who are scared about going forward and getting vaccinated, surely our next step is to put clinical experts, experienced, qualified GPs, whatever, to go and talk to those people individually, talk them through the benefits and the risks of taking up the vaccine. And that, to me, should be our priority. I think I'm being told that's already happening, but it's happened really well in adult social care, and I trust that we're all pulling together to do that and work on those particular groups that are proving resistant.
Thank you. And I also had Councillor Adams as well, just to do a final wrap up, and then I'll bring Jon Williams at the end after these three are answered. Councillor Adams.
Thank you, Chair. This is just, I was just wondering if you have any figures on the 12 to 15 years that has received their vaccination in Hackney. And secondly, it has been reported widely that the government is set to end the universal distribution of free lateral flow tests. How far is that true? Or do you know anything about that? Thank you.
Thank you, Councillor Adams. So there's 4 questions there: air filters, community outreach, 12 to 15, and free lateral flow. Over to you, Sandra.
Well, I'll start with the free lateral flow test. No, the answer is no, that's not true. I know it's been widely reported, but we've been told it's not true yet, I should say. We've been told by DHSC that they don't have the intention of withdrawing free tests, and that they are actually continuing to increase the number of tests that they buy and distribute so that we can have them locally. Chris is answering the question about 12 to 15-year-olds there, so I'll let him answer that and I'll come back to the others.
So again, just to give a plug to the council's website, we do have, I think, one of the best local websites which provides the data so that it is in the public domain. It's updated every single week, and the health intelligence team of public health do, I think, an amazing job. What you can find here is you can change the doses. For 12 to 15-year-olds, it's nearly all the first dose at the moment. There is now the rollout of the second doses, but what you can see here is if you just click on the bar, the proportion vaccinated is about 25%, and you actually get the change from previous weeks. It is a lower figure than we're aspiring to. There was some significant difficulties, I think, with the vaccination provider, which was Vaccination UK. That again, what we often find is there's a national way of doing things that doesn't always reflect the local issues that we have. And so for 12 to 15-year-olds, the message at the moment is that you can get your 12 to 15-year-old vaccinated by taking them to a local vaccination centre such as Sir John Scott or Bocking Street. There will be a further round of vaccinations being provided in schools, subject to the consent forms being signed by parents. And then what we're also looking to do is to do a whole after-school community vaccination events, which have worked quite well. So you're using the school as a setting, and then you're taking the vaccinators to the school, but you're looking at whole families and local communities coming to that school after hours to uptake on the vaccinations. So I think that was the vaccination offer. And then just in terms of the adult social care comments, it was something that we worked very hard as a council to do, as you say, to ensure that we had every single person who's waiting, who has yet to be vaccinated, who worked in social care or was in a care home, had individual conversations so that we could understand, one, what the barriers were, and then two, address them. That's also very much the approach now to that sort of neighbourhood by neighbourhood approach, and local GPs and local practices have been continuing to do call and recall. So for those people who haven't yet been vaccinated, they will be sending out text messages and invites, and then also looking to call people. And with pregnant women, it's been again a very successful program of increasing the confidence that pregnant women have in the vaccine, and then making sure it's as easy as possible to access, both in when you're attending your routine maternity appointments, but also making it really clear that you can turn up as a walk-in to community pharmacies or the vaccination centres.
Does one of you want to pick up on the air filters point?
Yeah, so we have been providing advice and support to schools about ventilation, including providing the link to the health and safety executives, quite detailed guidance on ventilation. But what we haven't been able to do, won't be able to do, is either assess the airflow, because we're not qualified to do that, or to provide individual HEPA filters for each space. And if you think about the undertaking, that would necessitate, you'd have to identify each space in each school where they couldn't get adequate ventilation by opening windows, and then buy an air filtration machine of sufficient capacity for each of those rooms in each school. And so we certainly can't do that as a public health team. But what I have done is with a group of directors of public health, we're drafting at the moment, is we're putting together a proposal to they'll probably ignore it, but we're putting together a proposal to DHSC to suggest that some of those unspent billions of money that Test and Trace are sitting on could be put towards improving ventilation in schools, and that probably won't be individual HEPA filters unless for a particular school they really only have one space that requires it. It might be more likely to be whole school ventilation systems, but that is something that will cost billions and certainly is outside of our scope.
Thank you for that explanation. With 1 minute over, Jon. Last word.
Just a quick question about the government thinking about reducing the isolation period down to 5 days. I've seen an epidemiological report from Japan indicating that viral loads are actually at their peak between 3 to 6 days. Would you be concerned about the government reducing isolation to 5 days?
Well, yes, I would be concerned about that. There's actually a really good epidemiological explanation for reducing it to 7 days. In the UK, and that's that we know that around 80% of people will no longer have detectable virus on board at that point, and that means that the likelihood that they're going to infect somebody else is massively reduced after 7 days. And that's why that change in policy makes sense, but also that to marry it with, you have to do a lateral flow test. What lateral flow tests are very good at doing is detecting high levels of virus, high quantities of virus, and of course that isn't exactly telling you that you're infectious or not infectious, but what it's telling you is that you're more likely to be able to transmit it because you've got very high levels of virus, whereas someone with lower amounts of virus doesn't mean that it's impossible for them to pass the virus on to somebody else. It just means it's less likely. So the combination of the lateral flow tests to release you from isolation before the end of the 10-day period, and then continuing with other measures like keeping away from people who are vulnerable, wearing a face covering, etc. And of course, there are different rules for people who work in health and social care anyway, just because, of course, they work with vulnerable people. Those are all really important safeguards. Reducing it to 5 days, that does mean that it's much more likely that people will still be carrying high quantities of virus. The change in policy in the United States from the CDC to 5 days is actually much more in line with our 7 days. It's about when you start counting.
It's a useful explanation. Thank you, Sandra. With that, I'm going to draw it to a close because we're slightly over time. Can I thank you for the update? Useful as always. Can I just quickly speed through minutes of previous meeting? Agreed, everybody? Agreed. Thank you. Work programme is at the back of the agenda. Haven't been notified of any other business. With that, I will close the meeting and thank you very much. Thank you for attending. Thank you very much.
Thank you very much. Yeah.